I'm very proud of you for being so professional in your white coats. I didn't tell you guys to do that, so kudos to you for that. Thank you for most people being on time. I'm Dr. Eschler, Deirdre Eschler. I haven't had the opportunity to work with all of your small groups, but I have with a lot of them. So hopefully you're enjoying the endocrine course right now. You guys will get very few, if any, education on transgender medicine. I would argue not just in medical school, but in your training. And so we thought, how can we teach you about transgender medicine? And I really think that it's not what you read on paper. It's really about allowing a patient as teacher to come in and teach us today. So we are very grateful. Tamara has taken off of work today. She's volunteering her time. She's very passionate about what she does. She helped us last year, and I've never heard a group of students be so quiet and respectful. So speaking of respect, please make sure that your cell phones are away. You don't need them now, right? I tell my kids, why do they need to take their cell phone to soccer practice? Your cell phone doesn't need to be out. There's no texting, and just make sure it's silenced, please. Okay? So we're going to start. Tamara, this is informal, right? Tamara's going to teach us a little bit about what she's gone through and what her story is. I will guide it with some questions, and then you guys are all welcome to ask any questions you want. It'll be about an hour. If we run a couple minutes later because you're interested and you have some questions, that's fine. We will, are you using this? Yeah. To be recorded on Echo 360, it's not for you guys, but for us. You have to use a microphone? Do you guys know? Yeah, okay. So, all right, so without further ado, Tamara is our teacher today, right? So, and she's a wonderful teacher.
Hey, gang.
So I think we're going to start, I'll stay seated, but we're going to start with Tamara telling us her story. Yes. So if you could take it away.
Hi, guys. I know you do a whole lot of lectures, right? And you see a whole lot of presentations. Well, I have it up here because, you know, my face is carrying, because I do presentations. I've done for Northwell, I've done for business groups, I do panel discussions, advocacy work. You know, so I do have an actual full presentation, but we're probably going to just jump around if there's any question. We're going to do this informal. I never like to speak at a group, so this is a discussion. Okay, so as we're going through it, if you have a question, just shout it out. I'm perfectly okay with that. So, who am I? Who am I? Woohoo! Okay, who am I? Gee, look at this handsome 24-year-old up there. Okay, at the time, I was Todd. And as you see, I have a whole lot of stuff over there. Now, Tamara, okay. I have a bachelor's in athletic training, specializing in exercise physiology and kinesiology. I have my master's in HR management, specializing in organizational leadership and change management. I am certified HR professional from the Society of HR Managers. I am a retired New York City paramedic. Did that for well over a decade. Believe it or not, that picture was taken in 1988. So I was born in 1964. I remember being 5 years old in the basement of my house watching Neil Armstrong walk on the moon. I am old. God. So, yes, as a paramedic, I worked at St. Vincent's Hospital in Greenwich Village in the city. I also worked Long Island College Hospital in downtown Brooklyn, where we covered all of Brooklyn North, Bed-Stuy, East New York, Red Hook, all of the vacation spots. Okay, so I was instructor trainer, certified instructor coordinator. I was BCLS and ACLS instructor, so I was on the teaching staff of both of those hospitals, even back then. So in July, if you start going into the ED in July, you would have seen my face teaching you ACLS. Okay, so I've done that. I was on the teaching staff, and for the past handful of years, I've been an advocate, or I am an advocate, for the LGBTQ community, specifically transgender community. I'm a speaker. I've done panel discussions, all of that fun stuff. Okay, so that's me. And if you hear me like a little out of breath, I want to apologize right now. My allergies have been kicking me around. So before I came in here, I took my inhaler. Okay, so if you hear me, don't worry, I'm not having an MI. It's good. Okay? Right, so that's who I am. Okay, I started my transition in 2015, 2016. Social transition. Okay, things that you need to know. I know you guys are like deep buried in your studies, that you really don't have a full grasp as to what's going on in the outside world, and that's the way it should be for you. But how many people understand the difference between a social transition and a medical transition? Oh, good number of hands. Awesome sauce. Okay, so yes, a social transition is you just start wearing different clothes, let your hair grow a little bit, or if you're a female to male, transgender, trans man, then you cut your hair a little bit. Okay, that's all great. You may use a preferred name. That's social transition, which I started, like I said, end of 2015 into 2016. 2017, I started my medical transition, which is hormone replacement therapy. Okay, started with androgen blockers, with spironolactone, as well as an estradiol patch. So I started that whole regimen 2017. So I was 53 years old. So if you want to do the math, I'm 61, by the way, okay? So that's why I say, yeah, that was a 24-year-old in 1988. So I've come a long way, baby. So yeah, that's a little bit about my story. Yes, there are a whole lot of challenges that I've been through, that I am still going through. Not to be political or not to put down anybody's political affiliation, but if any of you are aware of a lot of the legislation, especially that this current administration has, specifically targeting transgender individuals. You know, I remember, what was it, about 8 months ago, the TSA and Homeland Security, they had a web page up for, safety guidelines for LGBT travelers, which all of a sudden became safety guidelines for LGB travelers. Okay, the Stonewall Monument in New York City in Greenwich Village on Christopher Street, where the Stonewall riots in 1969 was actually started by Marsha P. Johnson, a transgender individual. The State Parks Department was ordered to remove all references of transgender out of that monument. Started by a transgender person. So there is a hyper focus on me. Even to the point where if some of you are watching some TV shows and some newscasts, they're saying that transgenderism needs to be eliminated. Yes, this past month, so far I've had my life threatened twice. And it was doing my food shopping. So, from your perspective, yeah, I mean, I'm going to go into, and Deirdre's going to ask me questions and stuff like that. You guys could ask questions. But from your standpoint, and I know you really have not done your clinicals yet, but from your standpoint, if you have a patient who is any part of the LGBTQ community, you need to understand what is going on socially, because this is what's going on, especially if you have a transgender patient. This is what's going on in their mind. Yeah, I could be coming in for my allergies or whatever. It doesn't matter, because every single day at this point in time in my life, in this country of great freedom, I am fearful for my life walking out my door. Something you need to know as a physician. Not just look at a chart and look at numbers. Okay? So keep that in mind. And I know you've probably heard it before, and you're going to hear it a lot. The patient is a human being that needs to be interacted with. Okay? So, That was a start, and I know that that was like a heavy sledgehammer type of thing. Sorry about that. But questions?
Yeah, so thanks for sharing that. You mentioned you went on hormones, so can you tell us a little bit about what the transition starting on hormones like? And can you also talk about what physical changes one can get from what's called top surgery and bottom surgery? Because I don't think the students have heard about that, and they should know about that as a potential future for transgender individuals.
Exactly. Hormones. Well, first off, terminology. You have cisgender, you have transgender. Okay, I am transgender. Trans means different than. Cisgender means in line with. Okay, and it's basically in line with what is your, what is your sex, which is determined at time of birth by the doctor. Baby gets born, looks at the baby. What's the reproductive organs? Congratulations, you have a boy. Congratulations, you have a girl. Okay? Because one thing to always keep in mind also, there's a difference between sex and gender. Sex is the biological aspect. Sex is the reproductive organs. Sex is chromosomal. Okay? Yeah, we have XX and XY. Okay? How many people know the aneuploids? You've heard about aneuploids and trisomies and tetrasomies. So yeah, we have XX and XY, but then there's also XXY, XYY. XX is it's 46.XX, 46.XY, 47.XXY, 47. There's so much variation in it. Okay, so just to simplify it down to XX and XY, can't do that. Gender is how you identify, and that's societal norms. Gender is societal norms. Give you a little bit of history. Before we go into the question, I know I'm skirting around, but give you a little bit of history. In the 10th century in Europe, who wore high heels? Men, specifically cavalry soldiers, because it helped them, their feet stay in the stirrups. Women didn't start wearing heels as a fashion until the 18th century Europe, and then came back out again in the 19th century because of pornography. Gee, ladies, don't you love that? Men want to see your legs, so let's make it pornography. Same thing, pink and blue. Pink is a girl's color, right? Pink is for girls. Blue is for boys. You know how that really started? That started post-World War II, because prior to that, the early 1900s, pink was a boy's color because it was thought to be a strong color. Pink was for boys, blue was for girls. Until post-World War II, when the advertisers wanted to sell more gender-specific clothing. That's when it started to flip. So it's societal norms is gender. That's why it's sex is the biology, gender is identification. Okay, so now if we start going into, hormone therapy, you guys know the hormones. Guys, what do you have? Testosterone. Well, women, you also have testosterone. Lower levels testosterone, your hormones, estrogen, progesterone. I always say testosterone is a sledgehammer. It's one of those big 20-pound sledgehammers. Estrogen is that little ball-peen hammer that goes ding, 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 ding. That's estrogen, which means that if any one of you ladies starts taking testosterone, within a year, your voice will drop because it elongates the vocal cords, loosens the vocal cords. That's why, a boy going through puberty is always talking like this, right? So testosterone, it loosens the vocal cords, creating a lower pitch. It also increases muscle mass as well as facial hair. So how many of you ladies want to grow a beard in a year? Not quite. But that's what testosterone does. Estrogen, however, like I said, it's that little ball-peen hammer. Yes, it does get rid of some of the hair. Body hair does not get rid of facial hair. So I have to shave every day. It does not tighten back up the vocal cords. So yes, I still have this voice. And especially if somebody like comes at me, then yeah, I throw the bass in, you know? So that's, so estrogen doesn't do that. Yes, it does have some fat redistribution. Usually, like I said, testosterone, you start seeing the results within the year, up to 2 years. Estrogen is more 2 years and beyond. That's why if you do get into transgender medicine, one thing that you will know about is the WPATH standard of care, World Professional Association for Transgender Health. WPATH standard of care says once on HRT, blood work needs to be done first year every 3 months and then every 6 months year after that. And it does give the timelines. Hormone therapy also is age dependent. So yes, if I would have started around puberty, I would have been given puberty blockers to stop the testosterone. When does the epiphyseal plates start to really solidify? What age? Okay, no orthopedics in here, huh? Okay, like late teens or so. So puberty, you still have the epiphyseal plates are still there. So there is a little bit of shift in bone structure at that age. But the older you get, the less changes there are. There are still some changes. Yeah, these are mine. Okay, then I don't have any plastic on me. But this is really about it. You could say what? I don't know, I have an athletic build. I don't know, whatever that is. But that's really the hormonal differences. And even with WPATH, and just to get into now a little bit of the politics, societal issues of this, it does cause other issues, such as impotence. I know when I started my hormone therapy, my endocrinologist had me sign a sheet saying that I understand that within 6 months, I will no longer be producing sperm. I get that. That's male to female, trans woman. Female to male, trans men, you talk about egg harvesting, just in case they want a baby later on, because the body will stop producing that. And that's also when it comes down to, again, I was going to get into the social, what is everything that's going on. Whenever you hear in the news or read in the paper, transgender, it's always me, trans woman. I always say, how come they never talk about trans men? We don't want men in dresses in the ladies' bathroom, in women-only spaces, bathrooms or locker rooms. Okay. Absolutely.
Is it stressful for you when you go into here, anywhere, to find a doctor?
For me now, no, because I don't care. Because the thing is, and that's why I love doing this, is the education aspect and the understanding. Is knowing that transgenderism is an identity. I identify, my hormones are she, her. My pronouns are she, her. I identify as a female. If I am going into a woman's restroom, I'm not going to rape another woman. I'm a female. I need to just go to the bathroom. But that's not what they understand, because they think that a man in a dress, just because I have a penis, means that I'm a sexual deviant, I'm a pervert, and I'm going to do all of these weird things to, all of the women and their daughters and all of that stuff. Which is not true, because it's an identity. Something like that, if you're afraid of men in dresses in women's room, that's a man issue, not a transgender issue. Okay, and I hope that throughout your careers, you help to spread some of this understanding. Because again, remember, let's go back to the hormonal aspect, testosterone versus estrogen. Estrogen does not do a whole lot of changes like testosterone does. Okay, which that means, Again, why in the news do they say transgender is always a man in a dress, and they don't mention trans men? Because I am the freak. I do not fit the societal norms of a female. Voice is low. Later on in the day, I have a little 5 o'clock shadow. My body isn't. And yeah, you guys all know, everybody is different. You know, there's different body types, endomorph, ectomorphs, you know, all of this stuff, so who cares about that? But the rest of the world doesn't. So I'm the freak. That's why I'm being targeted. Because obviously I'm a sexual deviant if I'm a guy that wants to do all of this stuff. So again, the mental and emotional aspects of your patient must be in your thought process.
Can you actually speak to that? You're obviously an advocate, right? And comfortable getting up here and speaking in front of people, but what is the emotional impact, not just on you, but in the transgender community? Last year you had spoken a little bit about the depression rates and the suicide rates. Can you educate them why that matters?
Oh, yeah, definitely. I mean, it even stems from the youth. If you look at some of the stats, like from the Trevor Project, LGBT youth have it's about a 41% suicide rate, and that's youth. That's 13 to 20 is considered youth. 41% because of the marginalization.
Those are staggering. Can you just stop for a second?
Yeah.
That's a huge percent.
Yeah, it is. And why is that? Well, there is gender dysphoria. Okay, that is a big part of it. Gender dysphoria, body dysmorphia, the changes in the body, because remember, transgenderism, the gender is the identity. Okay, you're a guy. I don't care if you're gay or whatever, you look in the mirror, you see, I'm a guy. You're a woman. You look in the mirror, you say, yeah, I'm a woman, and you go about your day. Someone who is transgender looks in the mirror and says, what am I? Because it doesn't match up. The way that I feel, the way I identify, and what I see does not match up. So gender dysphoria and body dysmorphia, that creates a lot of anxiety. That creates depression. And now add on top of that everything going on societally, as well as parents, friends. I mean, I do advocacy work also with youth, LGBT youth. How many of you at 12 years old, your parents said, oh my God, you're an effing freak, get out of my house? I'm glad to see no hands up. But that's what I've dealt with. People that have been kids, 12 years old. Mom, Dad, this is what I'm feeling. So instead of being like, let's go to a therapist, let's talk about this, let's see. Nope, get out of my house, you're a freak. 12 years old. I know a good friend of mine, Madeline, she started 12 years old. She was a sex worker at 12 years old, kicked out of the house by her parents. Churches, synagogues, you know, places of faith. You're a sinner, you're going to hell. We don't want you here. Add that with the gender dysphoria, with the depression, with the anxiety, with all of that stuff. 41% of LGBT youth, 13 to 20, have suicidal ideations, attempt suicide. 41%, almost half. In the workplace, even at the adult level, over 51% of workers are not out at work for fear of retaliation. For fear, because in the workplace, America is an at-will workplace. You know, over in Europe, an employer and employee, they sign a contract. In America, they didn't do that. Your boss could fire you at any time they want for whatever reason, basically. So 51% of workers are not out at work. A lot of the studies that are out are very limited because people don't want to participate for fear of retaliation. So yeah, I have, even my mother, 89 years old, thankfully, knock wood, I've had a very supportive family, my mother, my brother, you know, my cousins, stuff like that. My mother even just recently was like, you know what, with everything going on, maybe you should think about, you know, cutting your hair, you know, not wearing dresses or anything like that, at least like for the next 4 years. It's like, this is terrorism. So yeah, the suicide is just, and even now, I mean, Trevor Project hasn't done any new studies yet, but I could venture to guess that the suicide rate is probably higher now with everything that's going on. So yeah, that's big.
So how can these future doctors support the transgender patient and the transgender patient's family, right? Because I do have some parents who have come to me and said, my son just told me this. You know, how can we support both our patients who are transgender patients and our patients emotionally and our patients who are family members with a child making the transition?
Yeah, no, absolutely. Understand the standard of care. Understand the W path. Know all aspects of it, okay? Because
you can Google this.
yes,
You can get all these. I mean, because you know, we talked.
yeah,
Just digressing a second. What type of? How do you take estrogen?
right. I started with a patch, transdermal. There's also, and then I recently, a handful of months ago, went to injectables. So I just do an injection once a week. And then there's also oral administration. Same thing, testosterone is primarily injectable. But it's knowing and having a physician that knows what to do. I had somebody, because I also, I do advocacy work in the LGBT network, which is headquartered in Hauppauge. I'm part of the Workplace Advisory Council, Training and Education Committee, the Events Committee. I also run a support group that meets there twice a week. And, I remember a handful of years ago, we had somebody, a young person, who was female to male. The doctor didn't even go to an endocrinologist, just a GP, said, okay, fine, you want this? Here's testosterone. They were taking testosterone for 1.5 years with 0 blood work done. Remember what I said, testosterone is a sledgehammer. And, okay, endocrinology, what do hormone imbalances do to all of your bodily functions? How does it impact all of the other bodily functions? You need the blood work. You need to understand what it is. Please know that no matter what you hear on the news or anybody talking about, nobody in the LGBTQ community has ever advocated for any kind of medical intervention for any minor. Okay, the reason why I say that is because, the big thing that they like to say is, your kid's going to go to school as a boy and come home as a girl. No, it doesn't happen. Okay, WPATH standard of care, before you start hormone therapy, you have to be under the care of a therapist certified in gender counseling for 6 months to a year. And that individual must give the okay for hormonal therapy. And any kind of medical intervention needs to have, for a minor, needs to have approval of parents and the physician approval. Okay, so understand all of that. Now, how can you, if you have a youth that starts talking about it, hopefully you have a parent that's understanding. I would say know the resources around you. Here at Stony Brook, you do have an LGBTQ center. Okay, and you do have physician groups that are experienced in transgender, not just physician groups, but also counseling. Okay, talk with these people. Get the resources. This way you can guide them. There's also a lot of external resources. I know the LGBT network in Hauppauge, we do work here at Stony Brook as well. We're affiliated with Stony Brook as well. So know the resources. Understand. I mean, it's, in essence, I want to say what would you do if you were working on, you had a youth was a patient with the parents and you suspected abuse? What would you do? You have a duty to report. That's the law. Okay, so now how do you go through that? You have to know the resources that are around you. Wherever you are, your chief resident, your attending, HR individuals, social work. Understand what it is that you're looking at, and then go out to those resources.
And speaking of looking at, if I could interject,
Yeah.
I think the transgender community, Tamara wants to
Sweating.
get across, these are human beings, right? And so just like, you don't have to know all of the endocrine guidelines. If you're an endocrinologist, you should. But if you're an orthopod, you don't have to. But it's, I have patients who are undergoing immunotherapy for some rare immunodeficiency. So I ask them, oh, I don't know about this. Teach me about this. It's okay to say, hey,
Right.
I don't know what hormones you would be on. How often are you taking your estrogen, your testosterone? Teach me about this, right? I don't think that would offend somebody. I think it really just makes them be seen as human.
Absolutely, absolutely. When I first started, Northwell was the first on Long Island here to have a transgender center with Dr. Rosenthal. My endocrinologist there, Isabella Romano, that's when they had just started. So when I started seeing her, she said exactly that. We're going to be learning this together. I'm going to conferences, I'm learning this. So you and I will be learning this together. Me, I guess, being the background that I have, I was like, perfect. Perfect. But now, Isabel, she decided that she wanted to spend more time with her family than with me. But she actually was friends with my current endocrinologist, Dr. Carolyn Maxwell, here in Stony Brook.
Who taught some of you guys?
Yes. So, yes, don't be afraid to say, yeah, I've started working on this. Let me get some resources, and we will learn this together.
Speaking of learning, I
Yeah.
want you guys to learn what top surgery and bottom surgery
Yes.
is. Get sidetracked from it. What is top surgery? What is bottom surgery?
Mhm.
Is it okay to ask people if they've had top or bottom
Oh, yes, absolutely. And especially a trans man, remember it's female to male, that they could come in and be on testosterone and everything and look butch and all of that stuff, but they still have a vagina. So they still need that care. Top surgery is breast augmentation. Okay, for a trans man, it's usually a mastectomy to get rid of the breasts. Bottom surgery is also GRS, gender reassignment surgery. So you have a vaginoplasty for trans women. And there's different procedures for that. There's penile inversion. There's one, an abdominal, pedicle, I forget. It's something new that's being done up in Mount Sinai with Dr. Ting, where they actually take part of the mesentery, and that creates the neovaginal canal. And they're showing a great rate of better healing, faster healing, because the mesentery has its own blood flow, all of that stuff. So there's a lot of stuff with that. So you have top surgery, you have bottom surgery. Know also that for the trans woman, the male to female, there's a lot of other things. So many other procedures besides top surgery and bottom surgery. My voice, there are trans women that get vocal, that the vocal cords are snipped or tied to increase the range, but they also have to have, vocal coaching and stuff like that, because it's not just a pitch. Otherwise, you sound like Mickey Mouse. No, that's not how you do it. But there's also facial feminization surgery. There are a lot of places that specialize in this. The one place that I really know of, and when I decide to do mine, is going to be up in Boston, the Spiegel Center. This doctor does about 1,000 of them a year, has transformed facial feminization. Because if you look at you could basically tell from here up if you're talking to a man or a female. That's the way our brain works, because men have a prominent brow ridge. Women don't. Okay, the shape of the eyes, even down to the chin. Everything changes. Obviously, estrogen doesn't do any of this stuff. I remember when I was doing a presentation for some businesses, and I called it not medically necessary, because where I work, we have the insurance company, and I spoke to the insurance company, what do you cover? And they sent me the whole clinical, the clinical policy and everything. All of these surgeries were not medically necessary. Facial feminization, vocal cord, there's orchiectomy, which is the removal of the testes. There's a whole list of them, but the misogyny of it is that I would not be able to get top surgery, but a female to male, a trans man, could get them taken off. And I said, wait, why could that person get them taken off, but I can't get them put on? Well, it's not medically necessary, it's more cosmetic. Well, guys have gynecomastia, so guys sometimes have, yeah, but women are also like small-chested and stuff, so it's more, I'm like, no, this is misogyny now. So thank you, welcome to the wonderful world of being a girl, But that's some of the things that are being fought, and that's just knowing a lot of the stuff that goes into a lot of the surgeries that people don't understand. Even when at work, and I was talking to my VP of benefits about it, and he had no clue. I said, Peter, basically, I could come in, no jewelry, pull my hair back into a ponytail, wear a suit, not shave for a day or so, and I could come into a meeting, and I'm a guy with a vagina. And that's when it hit him. He was like, oh, wow, really? I said, yeah, really. Because insurance companies deem it as not medically necessary. So there are a whole lot of other surgical procedures, more so on the trans woman side than the trans man side. Because again, remember, testosterone is that 20-pound sledge. Estrogen is the little ball-peen hammer. So.
Can you touch on pronouns? How we can
Yes.
ask somebody what pronouns they prefer, how to properly address somebody.
Yeah, that's a big thing. Let me ask you, have you ever been to a party where somebody introduces you to one of their friends? Yeah, hi, this is my friend Steven. And you walk over and you go like, hey, Steve, pleased to meet you. And the person says, well, I prefer Steven. What do you do? Okay, Steven, pleased to meet you. Okay? Why is it so hard for me to have my preferred name? Hi, I'm Tamara. I don't want to call you that. Why not? It's my name. Because you're a man in a dress. I don't want to call you that. My pronouns, she, her. Because that's how I identify. No, you're not. You have that thing down there, so you're a he, him. It's, again, how I identify. There are also neo-pronouns, which, truthfully, even a lot of us in the community have no clue about. Yes, there's he, him, I'm a she, her. There are people that are, yes, we have LGBT. A lot of times you'll hear LGBTQ+, because there's a whole lot of other letters after that. Basically, you also have gender nonconforming, non-binary. These individuals can, one day I feel like being all feminine, the next day I feel like being all guy. Okay, those pronouns are they, them. Well, that's plural. And the person is a singular, so you can't use that. Okay, well, the other day, I was helping out this guy, Steve, and, they had to go and get their car really quick, so I just waited with his bags and stuff like that. How many of you heard me say they? We use it. Okay, so that's part of pronouns, they, them. The neo-pronouns are like ze, zeer, fey, fair, like all of these things, which, like I said, honestly, that I would have to say, talk to a youth, talk to a younger kid about. and to a point, my personal opinion, and I've said this a lot even within the community, is that I feel, unfortunately, that there are a lot of times when we ourselves are shooting ourselves in the foot because we cause confusion because of things like that. Hi, my name is Tamara. I go by Z-Zaire. You talk to, even you guys are probably like, what the heck, causes confusion. Even during Pride Month in June, I've had people like, oh God, I can't wait to go to the parade, and show me their outfit. And it's like, okay, you want to march in a parade to be your authentic self, but is your authentic self really walking in a parade wearing a G-string? It's not. You're an attorney. Stop. So there are times when we ourselves, the community, shoot ourselves in the foot. I mean, there's so many of them. Dylan Mulvaney, you've heard Dylan Mulvaney? Yeah. Okay, I mean, at the beginning, when she started, she's calmed down a lot, but when she started her whole TikTok thing with, day 1 of being a girl, day 2 of being a girl, day 360 of being a girl. But meanwhile, she'd be like, oh yeah, I woke up and I was really depressed and I wanted to cry, so I did what all girls do, is I go online and I shop. That's degrading to women. I'm sorry. And when you put yourself out there, then now you're representing me. So stop it. Which actually, last month I started up my own YouTube channel, which I nailed some of this stuff down.
So how do they access that?
I'm in the process. I'm going to be probably changing name, but for right now, the handle is Trans-cending Leadership. It's at Trans-cending Leadership. That's my YouTube channel. So I have probably about a dozen or so videos on it, and I go through a lot of the challenges that I've had, some of the medical stuff, because also a lot of things that people don't understand is, okay, so here's the aneuploidy and pterosomes and everything like that. But knowing, where did I have it? What does it mean? Okay. The biology of this. There are medical studies about the biology, that this is not just how I identify. Okay, there is a biological aspect. One of the studies done by Luders, back in 2009, there's another one that I looked up that was actually done in 2022, only 2 years ago. We all know that there are physical differences in the brain between female and male brain. Size, weight, and more importantly, clusters of neurons. And by doing electroencephalograph and all of that fun stuff, they could see where these neurons are firing. And they're finding that transgender individuals, majority of transgender individuals, over 87%, have similar brain structures as the gender that they identify with. Yeah, there is that other percent that doesn't, because they're doing it as a fad. That happens all the time with anything. But there is a biological component to this. Unfortunately, there aren't a whole lot of papers written on it, because again, the current administration decided to tell the CDC and the NIH to stop doing all studies on transgenderism. Obviously the initial thought is, okay, what are you trying to hide? But no more studies. So there are some papers out there. You have to dig a little bit. Whenever I do my research, I always look at, the National Library of Health. I look at the NIH. I look at PubMed. Real places. I don't go to like Wikipedia or Joe's transgender website. So you can look through these and you can see that, yes, significantly larger volume of regional gray matter in the right perineum compared to the men. New evidence that transsexualism is associated with distinct cerebral pattern. So there is a biological aspect to it. I think I skirted around that question a lot.
Have you ever encountered a negative medical experience?
Personally, myself, no, I have not, thankfully. Probably because when I see a physician for the first time, I say, this is my background. You can speak to me. You don't have to hold my hand through stuff. That's probably why. I have heard, yes, that people have negative. Again, you're not a woman. What's between your legs? That's a doctor saying that to a patient. Okay, one other thing also to understand with names and pronouns is your chart. I know Stony Brook does it. I know Northwell does it. I don't know if CHS, the Catholic Health System, does it. I think they're updating in the process. But there should be a field that gives the legal name and preferred name.
Yeah, so at Stony Brook, it's in parentheses.
Right.
You know, it'll say Deirdre D. I don't know.
Yeah. So when you do have a patient, obviously before you go and see the patient, you're doing a quick glance at the chart. Look for that. Because again, remember, that guy Steven that you met, that you called Steve, that preferred to be called Steven, you go up to your patient, even though you look at the chart and you see, oh, there's a preferred name over here, it is different from the legal name. You go, hi, I'm Dr. So-and-so. How would you like for me to address you? Catherine. Hi, Catherine. And go with that. That's it. How would you like for me to address you? You did the same thing with Steven. Why is it different now? I mean, you'll have a patient that's, hi, Mr. So-and-so. Oh, just call me Bob. Okay, Bob. Why is that not a big deal, but this is? How would you like for me to address you? If you make a mistake where you're talking and it's like, oh, Kate, oh, sorry, Catherine. Okay. And that's it. That's it. So just move on. Oh, gosh, so sorry. And move on. Same thing with the pronouns. She, her. Utilize the pronouns. Look over the chart. Understand your patient. And you should do this just as a general practice on all of your clinicals when you start having patient interactions. Hi, I'm Dr. So-and-so. How would you like for me to address you? How would you like for me to address you? Hi, how would you like for me to address you? That's it. Plain, simple. It doesn't have to be this whole big thing.
So I'll just ask one question in closing, and then I'll
Oh, yeah.
open it up to you guys. But if you could instill one big teaching point on these future doctors for the LGBTQ community, what would it be?
One big teaching point.
Just what you want them to know.
Yeah, bless you. Respect your patient, who is a human being. That's it. Yeah, you could, if you continue on and you work here, you go to a smaller place, you go out of state to someplace else, whatever. It comes down to the business aspect of it. Your patient is your customer. A lot of places, even when I go to see Dr. Maxwell, or if I go to another doctor, I'll get an email saying, take the survey, because I'm a customer. So treat me as a human being. I'm your patient. Yes, you need to look at your chart. Yes, you need to look at what are the numbers here. Okay, what are all the levels? What's going on? Blah, blah, blah. Do all of that. And yes, you could talk to that, but you know what? Close your chart. Say, how you doing? If it is somebody who is within the community, especially somebody who is transgender, you say, do you have a support system? Are you okay with your support system? Because if you want, I do know some resources that the facility has, as well as some external resources we can guide you to. How is your support system? Because again, I may be coming in for my asthma, but what caused my asthma? Because I'm afraid to leave my house because my life has just been threatened 2 days ago. Think about all of these things. You're dealing with a human being. And yeah, the business aspect of a hospital, even just of the medical profession, patient, 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 patient. The more patients you see, the more money, patient, patient, patient. You have like 5 to 7 minutes with a patient, go on to the next one. Okay, out of that 5 to 7 minutes, you know what? Even if you take the 5 minutes to review the chart and go over all of their stuff, take the other 2 minutes to close the chart and look them in the eye and say, how you doing? That patient will follow you wherever you go, because it's all that we want. It's all that we want, is just to be recognized and just to live our lives. And that's it. Any questions? Questions, comments, ideas, concerns? I know. throw stuff at me. Yes. Right. Um, yeah, I mean that's a great point. You have to look at the generational aspect of it. Right. Me starting my transition in my 50s. I mean, yes, when I was working at St. Vincent's Hospital in the 80s, late 80s, even going into the mid 90s, St. Vincent's Hospital in Greenwich Village, ground zero for the LGBT community, based practically in the world. You were a tranny, which meant that you were a gay drag queen or a prostitute. That was the connotation. I didn't identify as that. So that's when it was kind of like, I don't know what I am. So that's the generational aspect. Now the youth, it's all over the place. They know. So, right, when I first started, even going to the LGBT network, I knew that something was wrong, not wrong, I knew something was different with me. I just couldn't put my finger on it. Because again, being in the medical field, we had no clue. There was nothing about gender dysphoria. There was nothing about, transgender. There was none of that. Like I said, you were a tranny, which meant you were a gay drag queen or a prostitute. That's not me, so what the hell am I? That's the big thing, is the identity. And, so the kids now have it a whole lot easier, which is great. Even if they do falter with that, then again, I would go back to know your resources. Because again, it's to a point, it's abuse. If they don't know what's going on, and especially if there's a parent that, you suspect, yeah, my patient needs some assistance, but my patient is a minor and the parent won't let me, okay, something's going on here. That neon bulb should flash up in your head. Know the resources that are around you, that you could go to. Like I said, your chief resident, your attending, social work, HR, wherever.
If I could speak to that, you may
Yes.
be teaching or attending about this. Okay,
Yeah.
so senior faculty, they didn't get this education. They didn't grow up like this, right? And so you might be the person, the patient that is most comfortable with, because you're allowing the patient to be themselves.
Yeah. Yeah, exactly. Because like that story that I told you with the person that was taking testosterone for a year and a half, because their GP was like, oh, okay, here you go. Toss them a needle, here you go. But no blood work for a year and a half. How could you put any medication into somebody's body like this without doing blood work? So right, they don't know, unfortunately. So that's why, exactly, this is great. I was here last year. I look to be here for many more. Hope so, yes. And I've done residence, like I said, at Northwell and stuff, so they're picking up on it, which is a plus. Yes? My opinion on the current medical guidelines, it's perfect. Because of the fact that before any type of medical transition, you have to be under the care of a therapist who is certified as a gender therapist. So they're the ones that know, therapists, psychologists, psychiatrists, they have to be certified and know about this. And they have to give approval for hormone therapy. You could go with them for a year and, okay, I've been with you for a year, give me a letter to give my doctor so I could start hormones, and that individual could sit there and say, no, you're not ready yet. So yeah, it's definitely the right way to go. And this way you have so many different stakeholders. You know, you have your general practitioner, you have your endocrinologist, you have your therapist, at least to start with. That's the trifecta right there, which is good. Yeah. Right. Oh, absolutely. We always say that transitioning is like the Long Island Railroad. Okay, you could get on in Penn Station, and you could take it all the way out to Montauk. That's perfect. You could get on in Penn Station, you could get off at Jamaica. That's perfect for you. Whatever the individual identifies as and feels comfortable with themselves, so this way they could be a productive member of society, absolutely. There are people that, exactly, they just socially transition. Perfect. If you feel comfortable with that and you're happy with that, you don't have the depression, you don't have the anxiety, you don't have the suicidal ideations, by all means. You know, so yes, I always say I am an expert in transitioning. I'm an expert in my transition, not in everybody else's.
I would argue as well, it's different for every single person, right? I have a trans male patient, and he just doesn't want to get his period. He's not ready for hormones, right? So I usually say when somebody comes to me, what do you want out of this? What do you want, right? And so it's a spectrum. It's not black and white. It's not like, you know, get your thyroid out because you have thyroid cancer. Don't get your thyroid out. You know, there's a spectrum of this.
Mm-hmm. Right, exactly, and that's why we always, you know, also in the support group that I run, we say, whatever you want to do, nobody at any point in time should say, okay, well, you have been on hormone replacement therapy for 8 months, so now it's time to get your top surgery. No, it's not.
Some people never want top surgery.
Right.
Some people want top surgery right away.
Exactly. I mean, personally, I know that you've heard about my personal background, but to get a little, I guess, TMI, in my head, there are no plans for me to get bottom surgery. I just don't feel like I need to. So at this point, I'm not going to. It may change down the road, absolutely, but I don't want to now. Okay, no big deal. You know, so, right, the transition, you could stay socially transitioned, you could just do hormone therapy for the rest of your life. I mean, I did have a bilateral orchiectomy, so I did have my testes removed. So this way I didn't have to spend the rest of my life on aldactone. But other than that, I think I'm pretty good with myself. I look in the mirror, I like what I see. To a point, I do want to get some of this done. I don't like my nose. I want a nose job. I know. Mm-hmm. Right. Mm-hmm. Oh, yeah, absolutely. About individuals that detransition. The percentage of that is minimal compared to the community. People that I have like studied so far or looked to and looked throughout their history, the reason why they decide, oh no, I made a mistake with this, is because they didn't go through the counseling. They didn't go through the proper steps. It was, hey, I want to do this. Jump in both feet. And then all of a sudden be like, oh no, what did I do? You know, so that's really it. Yeah, there are individuals that do that and have detransitioned. If you look deeper into it, number one, the percentage is extremely small within the community that does that. I believe it's like 1%, maybe 2%. But then again, they didn't go through the process. You know,
Usually,
right.
if I could, sorry,
Yeah.
interject, it's usually, honestly, one of the most rewarding things that you can do as a physician, because somebody has come to you and they felt like this maybe since
because something to think about, again, what I said about being transgender versus, being part of the T versus the LGB is the fact that it's the identity, who I am. If you think about it, if somebody goes to jail, goes to a prison, prisoners have their numbers. Why do they have their numbers on their shirt? Well, because there could be so many John Smiths within the prison system, right? So this way it's an identifier. Well, yes, it is for that, record keeping. Psychologically, it dehumanizes the prisoner because it's taking away their identity. I mean, come on, if you woke up tomorrow morning and your reproductive organs were totally different, after a while, that's going to play with your brain a little bit, be like, what am I? So that's the big thing. When you have somebody that says, I am finally in the right place, that individual is such a better person overall. And yeah, I tossed this up just so that you know about some of the things that's happening as a quick visual, that this is a lot of the legislation. Note that in just 4 years, from 2021 to 2025, the number of bills, anti-LGBT and anti-transgender bills, 143 bills in 2021. So far, the middle of 2025, there was 851 bills that were passed, anti-LGBT, anti-transgender. And the safest states, the blue states, the dark blue and the light blue, I did this presentation, and this guy was sitting for the Huntington Advisory Council, and this guy was sitting there like, I don't want to be here, like that. And I said, okay, well, my daughter, she's 29 years old, she lives out in LA. Summertime, it'd be great. Go out and visit her. I'll rent a car, drive across the country. Now, where we are in New York, she's out in California. How am I going to get there? Look at the states that are in between. Okay, those states, and I'm not saying red or blue states, Republican, Democrat, those states have laws that are against me. And this guy, looked at me and he just said, excuse my language, wow, you're fucked. And I said, yeah, I am, because I can't. Notice Texas and Florida are the darkest. The Human Rights Campaign has designated those as no travel zones for LGBT travelers. And going through Congress, this past March, the Texas gender identity fraud. My niece is down in Texas. She works for a law firm down there. Well, her and her boyfriend, soon to be fiance, I hope that they don't decide to get married in Texas, because I can't go there because there's a gender identity fraud bill that was passed. I could step off the airplane, a TSA agent look at me and be like, ooh, something's not right there. The gender norm is not right there. Pull me off to the side. Now, that's a felony, 2 years in prison with up to $25,000 fine in the great state of Texas. Okay? They also have all of the the DEI legislation, which I just want to say, DEI does not mean LGBT. You are all DEI. Diversity. This whole planet is full of diversity. Diversity, equity, and inclusion. It does not mean LGBT. You guys probably have it here. I know in businesses we have ERGs, employee resource groups. Yes, I am the leader of my LGBT ERG where I work, but we also have an employee group for women. We also have black employees, we have Asian employees, we have Latina employees, we have military veteran employees. The Americans with Disabilities Act turned 30 years old, one of the first DEI initiatives. That's why we have handicap parking and handicap ramps. That's a DEI initiative. When you hear DEI, it does not mean LGBT, it means everybody. So that's why I just wanted to toss that up there, just as a little visual to keep in your head.
So I think for the purposes of time, we will give Tamara a big round of applause.
Thank you. Oop, thank you. And yeah, last visual, just quickly. You hear a lot of legislation of biological reality. Aidan Dowling and Anya Marino. Aidan Dowling was on the cover of Men's Health magazine. Okay, guys, how many of you read Men's Health? You know, for fitness and all of that stuff. First transgender person on Men's Health magazine. Okay, so biological reality. I don't want a man walking into the women's room with my 5-year-old daughter. Well, Aiden is going to be in that bathroom. Anya Marino has a BA in anthropology, has her Juris Doctorate, so she's an attorney, one of the first transgender women of color to be hired by Harvard Law, to teach at Harvard Law. Guys, biological reality, she'll be in the bathroom with you. Understand trans women, trans men. If people don't understand that, Google it. Hey Google, hey Siri, trans man. Like I said, a year on testosterone, you got a beard, you got muscles, but biologically, you're still a woman, so you gotta go to the ladies' room. Yay. So, okay, that's my close. No more after this.